Approval of the minutes. Has everybody read the minutes from the last meeting?
I have.
I move.
A second.
I'll second.
All in favor, say aye.
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 Okay, motion passes. Okay, we have one primary item for the agenda tonight. It's called recommendations regarding personnel safety measures during the COVID-19 outbreak. And, you know, the notes that Christina sent us seem to be pretty thorough and covered the bases pretty well. And so at this point, do we have any suggestions as far as additional points of interest or corrections or fine tuning of any of the comments? Or any additional potential reading material that you think we might want to take a look at? Okay, well, does anybody have any questions regarding some of the 12 protocols? Well, I have a couple of things that I might just mention and see if it stimulates any thought or comments. With the very first one, health screenings for staff and public entering our facilities. I presume that's just temperature and travel questions?
Well, it can be really simple. With the travel questions, we're not asking travel questions because, in all honesty, it changes so frequently and so quickly that keeping staff up to date with somebody who says, I traveled to Maricopa County, Arizona a month ago would have been absolutely fine. You know, this week they're having some problems. So what we just focus on is we find out how they're feeling. We ask to take their temperature. We ask them if they're having any breathing issues or any exposures to anyone who's had COVID-19 or have they had it themselves. And then we kind of go from there. It can be a really, really short conversation. In most cases, every once in a while, someone says something that triggers a more in-depth conversation with them before they're either allowed to come in the building or essentially provided accommodation to conduct their business virtually or over the phone.
I presume there's a questionnaire, a form that you guys use to go by? And
we do. All the health screeners have a common form that they go through, kind of a, I don't know, a checklist, a little way that feeds them through. However, you know, they don't, I guess you could say they don't mark anything down. They don't take any notes as they go because we don't want to be creating a medical record as we go. You know, the health screeners are not doctors. And we know that. So they ask some of those basic questions. And if any time that they do have an issue or a question, you know, there's a staff member to reach out to get them as close to an instantaneous response as they need.
Okay, so they do have backup if they have a question about an answer they've been given. Okay, great. Yes. And they do have a pretty much a protocol sheet to feed them, to walk them through the process.
Yes, they have a step-by-step. If the person says this, then you need to say that and ask this question. And then if they answer this way, then this is your next step. So we go through that and they all get trained. And the ones we've had doing it right now have been doing it for a couple of weeks consistently. So we had one group that did it. Yeah, we had one group that did it in June for the whole month, and then we have another group that's doing it in July. So they are actually getting really good at it. So
they'll be around and available for the next protocol, for the next pandemic that comes through.
Well, you know, I think they all have a new set of skills that they didn't have before. So I'm going to give them that. Okay.
Any other thoughts or comments based on that? What she just shared? Okay.
I am interested to know if you've had much pushback from people answering those kinds of questions. I just was peripherally involved with somebody that said they had a mask exemption, and when they were asked what their mask exemption was, they opened their jacket and showed their 9mm And most of us are not geared up to handle those kinds of situations very well.
And probably once a day, one of them has someone who either doesn't take the questions seriously or tries to just push past them or does something. They've all been trained not to engage, to ask the questions, to make sure people know they're taking it seriously, but that in all honesty, if someone's going to cause an issue, then they are not the right people to deal with it. Our police department is well aware that the health screenings are going on and know that all the screeners know the number to call if there's an issue, because they are not trained in de-escalation techniques and they are not trained in trying to make sure people are safe. So, but it's actually been very rare. I've done it multiple times now. And in fact, if you guys ever come to a council meeting in person, you'll come across me taking your temp. And I've had very little pushback.
It's pretty harmless and didn't hurt at all.
No.
Okay. Number 2, I didn't have anything there. On number 3, public spaces, when it says wearing masks in all public spaces, is that indoor, outdoor, or both?
Well, it's indoor at all times unless you're in your own enclosed office. If it's outdoors and it's a public space like a farmer's market or anywhere where you can absolutely not guarantee that you will keep 6 feet of space between you and the next person, then that mask is required. And our staff all know that. And we are constantly trying to reiterate that to staff and the public. The farmer's
that's a little
market,
more difficult when I'm sure that's when you might get more pushback on in that kind of a setting, even though it's outside.
and there have been a few people I know who have had an issue coming to our farmer's market and wearing a mask. However, that being said, the order does specifically call out farmers markets as one of those locations where they need to be worn. And we are going to abide by that county order. So we understand people may not disagree, but it is something that we feel strongly is for everyone's safety. So.
Okay. And let's see. Number 4, that looks like that's pretty much a case-by-case situation.
Let me switch over. Hold on, let me switch over and look to see what number 4 is. Scroll back up.
The self-reporting of travel outside the 125 miles.
Yeah, so that's for, that is really truly a case-by-case situation. I actually am the one who reviews it for all staff. They know that if they're going to be traveling outside of that for personal reasons, that they turn in a form, they say where they're going, they're safer, how long, and everything else. And a couple of weeks before the travel's going to take place, I go and I essentially look at county level data to see what's going on there. Whether it's trending up, whether it's trending down, what's their per capita infection rate, what are their new daily case counts, all of those things. I go into depth, and then the week before they get ready to leave, I look again to see if anything's drastically changed. And then when they come back, they're supposed to check in a couple of days before they come back to work to make sure that if they went for 2 weeks to Florida, that it didn't all go bad while they were there. And if everything's still good or at least comparable to what we're seeing here, then they get to come back. Otherwise, we go ahead and we have them quarantine. If they can work from home, we allow that.
Okay, great.
Hey, Christina.
Yeah.
Hey, Daryl Nelson. For what it's worth, we've discontinued screening related to travel and quarantining. The CDC's no longer endorsing it for healthcare. We'd be without a workforce probably through the summer if we did. So just an FYI, I mean, kudos to you for trying to do that. It would be impractical. We don't know how we do it with 1,500 employees and 700 physicians and physician assistants. So we had tried early on, but we've not been able. And the argument is, frankly, with prevalence in a majority of the states, it's hard to know when you're going to catch somebody getting right there when the prevalence flips and all that. So anyway,
And
I mean, I
yeah,
don't not support you doing it. I'm not sure you're going to get a return for the time you're investing, to be honest with you.
and I don't know either. The honest answer is we went back and forth on this one.
Sure.
And we decided that, as long as we can,
Yeah.
we're going to try everything we possibly can to keep our staff safe.
Sure.
Any other questions or thoughts on that?
Hold on. Dr. Ruddy, you're muted.
I am now unmuted. So on the quarantine piece, are your HR policies such that you have some folks that can work from home and then you have others that don't? And some policies are in place that allow for it, and while others do, from an HR perspective, are you able to manage all your staff who may be in different spots with regard to that request? Some people may have time, some people may not. How are you managing that?
Or the best we can is the correct answer. And what we do is when they fill out the form, that form comes to me and our HR director. When it's sent back to them with the recommendation, it's to their supervisor, it's to them, it's to HR. Everybody in that chain really knows what's going on. Is it perfect? Probably not. And I'm sure there are some that just don't fill it out or just don't admit where they were. However, for the most part, all the directors are on board. We understand that there's some staff who, even some of our field staff, if there's a way to find a job for them to do at home, we're going to attempt to do that.
Okay.
We want to make that allowance. We want to help them. I'm not going to say it's a perfect system and that it's able to happen every single time. But we're trying to give them that best update. If they decide they want to go to Tampa to go to the beach this weekend, well, we're giving you a big fair warning that you may be taken off more than just your 1 week.
Well, that's probably more important that people understand that given this request and where you are with leave and other kinds of factors like this, you may be impacted. And I want folks to know up front before they make that decision, as opposed to returning to work and finding out, I've just took vacation, I don't have any more leave left, where I've used I could be looking at a reduction in my pay.
Yeah, and we are communicating that the absolute best we can. And in fact, if there's places where, right now they don't seem any worse than we are. However, the areas around them, the counties around them are trending upward with some exponential growth. I tell them that straight out. I say, listen, I know you're 2 weeks out. Right now, my recommendation is that you wouldn't have to quarantine. However, I am going to look at this again next week, and it may be a very different story.
Okay.
So we are as honest as we can.
Thank you.
Christina, what is your threshold on that when you mandate a quarantine? How do you make that final determination?
I am comparing the location that they're traveling to the KC Metro. What was decided is, a lot of people say, well, it's just as dangerous for me to be here as it is for me to be in Nova Scotia. I don't know. And so what we do is we really look at that. Is it truly, is their caseload like that? Would it be as bad as them going down to Power and Light right now? Or is it exponentially worse and more likely? And so we kind of look at that threshold and I compare not only the per capita data, but I look at the daily case count. I look at how everything is trending for them. And I go ahead and as part of my recommendation, I will go ahead and quote some of those numbers to the individual so that they see yeah, it's not that bad, but it has, increased by 6 times in the last 2 weeks. So you are aware this is an extremely bad trend, and you should probably consider, vacationing somewhere else.
So is that threshold, if it's greater than what our percentage is here in Jackson County, then you would require them to mandate, or does it have to be a certain percent above our county rate, or what is that exact threshold that you utilize?
I don't have an exact threshold, and maybe I should. Maybe that's something that I should say if it's, 10% worse or something like that. What I'm looking for is, if we had, 50 cases, today, and they're having 60 cases, I say, well, that's really not that different. If we have 50 cases and they're having 150 a day, I'm like, well, that is a substantial difference right there. So there's no science to that part. And if you guys recommend it, I will totally put science into it. Tell me what you guys think. But I am just watching the numbers for our area change and trying to make sure that it's the same level of threat, I guess, when people travel as we have here.
I would ask Dr. Darrell what his consideration is with this particular topic.
Yeah, I mean, I think the only thing that I would think that you might consider is just what you said, Christine, is maybe define it just so people don't assert that you're making a subjective decision. And I wonder about what return you're getting, just to be honest with you, investing that much time and analysis on each. I mean, I have no idea how many staff you have or how many are taking time off. And then, like I said, the CDC, at least for healthcare workers, relaxed that and just said they didn't feel like there was any way to provide guidance about who should quarantine and where they should go, and encourage just tracking of symptoms. And, we are just so struggling with this condition in the whole pre-symptomatic and asymptomatic phase as well. So we've got folks amongst us, frankly, who haven't traveled anywhere and are sick and don't even know it. So I think that's the only reason. I have no criticism with all the efforts you're trying to make. I mean, everybody's trying to find ways to make our communities safer. So I would just make sure that you don't inadvertently put yourself at any risk if somebody challenges you, maybe by defining what you're going to use as the threshold. But aside from that, that's what led us to make a decision. We were just struggling, and we were pretty convinced people weren't being forthcoming about their travel, and made a decision just to discontinue about 2 or 3 weeks ago. All the major health systems have stopped. We are on a citywide call every week. KU, St. Luke's, all had been quarantining after travel and had discontinued within the past week or two, at least as reported on the chief medical officer call last Wednesday. So.
I might ask if there's any other out of these 12 protocols. Would you suggest any others that might be considered optional to keep, or based on your experience, because you're in the healthcare industry, and if you consider something to be really unessential, I know how much time that this pandemic has created, how much more difficult work has been for a lot of folks. So if there's anything that can minimize the time and effort that has to be put into all of this, I think that would be great. And I think Christina probably would appreciate anything that can be deleted. She probably wouldn't mind at all.
Yeah, no, I thought the recommendations generally otherwise were pretty much in line with what we're doing and what I hear from our fellow health systems across the metro, as doing both for their workplace policies, for their policies with their medical staff. And then frankly, what we're grappling with is just, do we have to rethink even our single visitor? Because to be honest, our screenings are just not working. We've had family members in earlier this week and had a lady ready to go to surgery. She'd been in the hospital a week and went ahead and just tested her prophylactically before surgery, and she was positive. And when we reported that to the family, 2 of the immediate family members admitted they were positive, but had not been admitted to screening folks to the questions because they wanted to be able to get in and see their loved one And they either not had fevers or managed their fever down when we checked their temperatures with antipyretic medication. So we're just seeing the reality of trying to manage this as the community prevalence grows, and it's challenging. And I don't want to sound like we're conceding. I think we're just adapting to the change and imploring people to assume that folks you come in contact with potentially have COVID. And, we're touting universal protection, similar to what we touted 25 or 30 years ago with the advent of HIV and universal precaution at that time, because we had to try to figure out, well, who might have a bloodborne illness? And we realized a long time ago that everybody might potentially. And so now we're thinking the same way about the potential for airborne illness. And the data is really difficult. We're only seeing 5 to 10% herd immunity being reported in communities that have had over 50% penetration of their population. So we see a long haul here ahead of us, with not a lot of, definitive fix type tactics. So it's really going to be managing, and that's, managing masking and hand washing and kind of back to the basics that people roll their eyes about. But it looks like for the foreseeable future, it's probably going to be what we have best available to us from that standpoint. So I think you're right. And I would just suggest that the staff continue to reassess as this continues to evolve, kind of how those tactics are working and what needs to be, tweaked or changed. We're meeting several times a week and reviewing CDC and HCA corporate data, and it literally sometimes changes by the hours. And I know you all have heard me through this pandemic make that reference, but here we are months in, and that's still what we're seeing. And then we're frankly concerned that we're seeing the rate of escalation in the middle of summer. I mean, our infectious disease experts say generally these viruses really don't like hot temperatures, and that's why we historically see seasonal viral infections go up in the fall and winter. And so that is getting a lot of attention as well, to see that there's essentially no regard for the seasonal change here from that perspective. So anyway, then lots to consider and work on an ongoing basis. And our local hospitals, just as a quick update, are definitely seeing upticks. We nadered about a month ago for all of our health system. We had single-digit admissions at research in early to mid-June, and then as things started to pick up, as you saw in the news and here, we're now up north of 45, and all the health systems reported increases, not so much in ICU admissions or ventilator patients, but in overall patients sick enough that they are requiring hospitalization. So we feel like it's likely coming to an area near us. We're just hoping we can blunt it with the infection control tactics a little bit.
Daryl,
it's Don Potts. What are your criteria for hospitalization versus sending someone home if you are comfortable?
Yeah, if they don't meet admission criteria unrelated to COVID, based on their hemodynamic stability, oxygenation status, those sort of metrics, then frankly, Don, we're not even testing them. We're sending them home as presumed COVID, which is what the systems are generally doing around Kansas City because of the continued capacity restraints with reagents. FEMA is now involved and is essentially managing distribution of the testing reagents. So even for those systems who've been in a better position than HCA with their testing platforms, are now struggling as well because reagent distribution is being controlled. So we're only admitting them on the basis of symptoms that can't be controlled in an outpatient setting, and then only testing once the decision's made to admit them, because in our system that determines where they'll be admitted if they're positive versus not.
Okay. Thank you.
You bet.
Daryl, this is Terry Morris. You mentioned herd immunity, and that's one of the big challenges is to, I'm unfortunately one of those people who sometimes know that the light at the end of the tunnel is a train. And we rarely have developed herd immunity to COVID viruses in the past. And there's actually no data yet to really say we're getting antibodies and we're getting T cells.
Right.
But we don't know if 3 months down the road that's going to provide any immunity at all. So just because you had COVID doesn't mean you're not going to get it in the winter when it peaks back up. So it's just...
Yeah, we've actually seen people, Terry, who clinically cleared from some of the early exposures in the spring and sought antibody testing and had antibodies, and then have showed back up at least once. And I think our employee health nurse has one lady who we think may have 2 separately times, which seems hard to believe in such a short period of time. So I don't know about that, but we're certain we've seen cases that were positive early on, completely cleared, returned to a state of well, and then have tested positive again. So I think that's reaffirming some of the concern about what it's going to take to create an impactful level of immunity.
It's not boring.
Exactly. Oh my gosh. If you'd ever told me as a family doc and a CMO I'd be managing through this, this isn't anything I could have began to have dreamt up. So
yeah, retirement's not all that bad, is it, Don?
I just turned 58, so maybe it's time to think about that. I thought I had a few more good years in me, but wow, this has been a doozy. And the medical staff teases me, because they say, oh, I got a question about COVID. And I go, oh, really? Can I talk about just something other than COVID today? But so.
Okay. Any other comments about this particular topic? Any other thoughts coming up through the next several protocols? Any questions or comments?
Ralph?
Yes.
This is Kathy. I don't see anywhere in here, and wondering what they do with cleaning of like the police cars. Are they picking people up? I just saw Public Works and there were 2 employees in there today. What are they doing for cleaning their vehicles?
So for the police department especially, I know that they're making sure that they clean in between shifts because, your car that you use today may be used by someone else tonight.
Right.
So they are making sure, they have a protocol that we worked on to make sure that everything gets cleaned. For public works staff, if there's 2 members, ideally what you're supposed to be doing is cleaning. I can't promise you that public works staff is cleaning, but normally a vehicle is assigned to that individual. And so those people riding around together will all pretty much are usually partners who ride around together all the time. We're trying to minimize as much as we can people using equipment that will then be passed off to somebody else without making sure that that is deep cleaned. So we are doing what we can. If there's a suggestion.
I just didn't see it addressed at all in any of these standards, and I just wondered what they're doing about equipment, because police are out there on the front line and picking up people.
Yes, they are. And believe me, it has been something that we have discussed from the very beginning, because we've had, a lot of their clients that they deal with maybe exhibiting symptoms, but not have had a test, nor do they wish to have one. So we have been talking from the very beginning about how to make sure that all of their gear, what they're wearing is able to be cleaned down, that if they've come in contact with someone who is a possible exposure for them, making sure that they're changing clothes and they're getting themselves cleaned off. They're making sure that the vehicle's cleaned, that everything gets cleaned. And then they're making sure that they're not passing anything on to the next guy.
Okay, thanks.
Okay, any other thoughts on any of the rest of these protocols? I thought the one more thing that I might suggest, and at some point, you know, with this number of protocols that you have, sometimes there are things that might get overlooked, and if there's a checklist in some cases for different situations, that might be something to consider as far as just making sure that, you know, people are consistent and they can learn how to do it without forgetting anything. And that's about it. And then the only thing I might ask Dr. Darrell one more time, does he have any recommendations for places to go that we might, you know, review and, you know, keep reviewing as far as, like he said, it changes daily. And so where would he recommend in addition to the CDC?
Yeah, we really rely almost solely on the CDC. There are other health systems and entities who are publishing. Johns Hopkins has gotten out on the front with a fairly significant site that provides a lot of update data. But generally speaking, for the kind of operational decisions that need to be being made and evolved, the CDC really has been a good source for us, and it's easily searchable. So that's really primarily where we've been. Occasionally, the World Health Organization will take some sort of a position that might be slightly variant. It's more often on some of the statistical data around how we're defining levels of the pandemic and those sort of things versus actually operational issues. But CDC really does a nice job, and you can search your way, you know, as far into the weeds as you want to get when it comes to looking for policies and protocols and preventative strategies. So that's really our primary resource. We have a team of folks that helps just troll that regularly at HCA Corporate, and then they tend to publish kind of highlights, if you will, because there is just so much going on to try to help make sure that our attention on the front line is called to the, you know, the most critical areas that are changing rapidly. So.
Okay.
Carol, that does, this is Terry Morris again, and that does beg the question, do you, since you're in the pipeline with the hospitals, do you anticipate any significant changes with the, not wanting to wax political, but the recent decision that hospital admissions and data are going to be shifted away from the CDC primarily?
Yeah, you know, I don't know for sure. I just started to pick up on a little bit of that recently, and we haven't seen or are planning for really any substantive change yet, as you know. And one of the big criticisms has been in just some recent op-eds and other articles that have been published is, you know, just the politicization, unfortunately, of the management of this versus, you know, the clinical or the scientific management of it. Like you said, it can slip into a contentious conversation quickly, but I just don't know what other pipeline, at least that I've ever really depended on over the years, would be so accessible and helpful. I mean, we use it every year to help guide our seasonal influenza approaches anytime we're dealing with any other sort of outbreaks. You know, they've really just historically been a resource. So I guess it's, you know, easy in times like this where it's so difficult and things haven't gone well to kind of question or pass judgment. And we'll certainly look back on this and try to learn. But right now, that's going to continue to be our source. So
just the key is accuracy of the data we have. That's our problem with the county and the city. You know, we don't know what we don't know what we're getting from whom.
Yeah, no, understand.
One more thought that I have is in regards to the long-term, how are you going to make your decision? Do you have a protocol for how often to review these, how long to, you know, carry them forward, and when do you decide to, you know, drop them? Or some of, you know, like hand washing, you know, that's something that's a protocol that's always going to be around, so it should be on the list just because. but it's still, it's when the protocol is no longer needed, hand washing will still be there. And some of these are like that, I think. And, you know, which ones would that be? Things that you would, you know, we're more aware of this kind of situation, and it's going to be recurring. So what are you going to consider as ongoing kind of things, and which ones are the ones you would pretty much say, well, until the next one, we don't need to do this anymore? Any thoughts about reviewing and you know, some of the different things that may be ongoing?
Is this a question for Dr. Nelson again?
Oh no, I'm putting it back.
Just to anyone?
Yeah, I think this is a day-to-day kind of process. I mean, the data comes in, you just have to assess it, and you know, if we wind up to be a hotspot or the rural areas around us, I mean, we have these weird hotspots in Lafayette County and just places where you don't expect things to pop up, and they do. And I think you have to look at it every day or once a week. Or
that's the question I have. How often should this be reviewed? And at least, you know, we're still in that you know, current event situation, and then eventually it'll taper off. And then, you know, how long do you carry on forward with some of these protocols before you say, well, I think we've gone long enough with this particular one, or these 10, or these 3 or 4. And it's time to take in the, you know, put those on the back burner until the next episode.
Well, I can tell you right now what we're doing is I'm reviewing information every day as it comes in and trying to stay up to date as possibly can, along with the rest of the incident command team. I know that we are assessing every couple of weeks where we are with our numbers, and once a week we're having meetings where we're talking to the county, and we're discussing essentially how this is going, how the county thinks it's going, where we are, whether we stay in the current phase or whether we think we're going to be close to the next phase, and when we're going to reassess that. You know, we do some really hard looks usually towards the end of the month. I know a lot of people are expecting things to switch. You know, apparently, you know, June 1st, July 1st, they just expect that somebody's going to make a change once a month. So we try to make sure we have that hard look to see where we are as a city. But the honest answer is we are looking every single day at our numbers. And I told someone earlier today that I need to write a letter to my algebra teacher and thank her, because I've never realized how much algebra I would be doing as I was trying to figure out the per 100,000 stats for all of our cases. So I have to find time to thank her.
Thank God for math. Okay, any other thoughts or concerns or comments that you want to make before we wrap this meeting up?
Christine, are you getting better numbers from the county now?
Are we getting all the numbers we would like? No. Are we getting more numbers? I mean, we're getting more, and our conversation, we're, like I said before, we're at least having a weekly conversation, and we have made some good contacts that when we need to reach out, you know, they're giving us some of those good, honest answers. And they're actually doing a really good job of taking feedback right now. You know, we're suggesting things that we would like to see on the website, data that we would like to see, and they're listening and trying to accommodate.
Any other comments?
I was just going to ask if their contact tracing has fallen better in line, because before they weren't allowing any volunteers and they had nobody to do the job.
Contact tracing is still something that they are working to hire additional contact tracers for. it is still something that is definitely needed.
Okay.
Christina, the Medical Reserve Corps has done quite a bit of recruiting for contact people, and so they are actively engaged in that right now.
And I know that other counties have actively taken that on and have accepted that help from the Medical Reserve Corps. We have continued to offer Jackson County whatever assistance they need, whether it be through the Medical Reserve Corps, whether it be through our firefighters doing contact tracing, whether it be through former health department staff, whatever they need. And I can promise you that every conversation we have with Jackson County, we reiterate that we are there, we are ready, we are able with whatever they need. They just have to ask.
Okay. Any other thoughts or comments? Well, I want to thank everybody for coming and taking your time to discuss this. This is not the last time we're going to be talking about it, I'm sure, but I appreciate all the hard work you put into this, and you and all the other staff that work with you. And I think that, this time that you take for all of this, it could be better spent on other things if we didn't have this to worry about. But I'm grateful that we have qualified people to take care of, doing the day-to-day things that are necessary to keep us healthy and safe in our community. And thank you very much. If there are no other comments, I call this meeting adjourned. Bye, guys. We'll see you.
Good night, everybody.
See you in August.
Night.
Have a good evening.